After court challenges and impassioned pleas from terminally ill patients, people in Canada with an incurable illness for whom death is, quote, reasonably foreseeable, now have the right to request the help of their doctor to plan and carry out ending their lives. Passed last year, Bill C-14 is not without its critics, both in substance and implementation. Joining us now to explore where the law is and is not working, Father Raymond de Souza, chaplain for Newman House at Queen's University and the editor of convivium.ca, and James Downar, critical and palliative care physician at the University Health Network in Toronto and member of the Physicians Advisory Council for the group Dying with Dignity. Good to see you, Father de Souza, back here again.
Thank you.
James, for the first time. Nice to have you here as well.
Thank you.
Let's get a better understanding off the top. We've heard the specific example. Let's now take a sort of, from 30,000 feet, as they say, look at what's going on here. The new law, where's it working?
I think it's working in the sense that it has now defined some sets of criteria where people can request and receive medical aid in dying, clarifying that and putting some structure in place where people can actually understand what situations they can access medical aid in dying is good. The law also is good in the sense that it took very specific controversial situations such as people with primary mental illness, people with a disease that would result in them losing capacity, or mature minors, and put them aside for special consideration, not saying that they would be included or excluded, but that they would require further consideration. I think those are all definitely positives.
Where is it not working?
Well, the mechanics of the law may work well, more or less well. I think primary objection to the medical assistance in dying, which itself is a kind of a euphemism, but is that the law protects the life of the sick and the vulnerable, as we have laws that protect truth, laws that protect property, and so forth. When you change that, you change an ethos. So even if the technique or the steps or the procedures might work more or less well from an efficient point of view, the primary objection, not just from a religious point of view, but from a philosophical or legal point of view, is that you have a less protection for the good of life, especially life that's vulnerable or weak. Now, as Dr. Downar mentions, at the moment there are special categories for things that will be dealt with later. We'll see how that goes. But once you remove that sort of fundamental disposition in favor of life, all those who are vulnerable are less protected than they were before.
Does it feel to you, though, Dr. Downar, as if that debate, your main argument here is not with the law itself, it's with the...
Well, I oppose the law itself.
You're opposed to the law, but you have a bigger concern beyond the mechanics of the law.
Correct.
You're against the whole idea, generally speaking.
Correct.
My response would be to say, first off, that while I certainly recognize and respect that there are many people, Father de Souza is not the only one who have a philosophical disagreement with the idea of legalized medical aid in dying. I would point out that the evidence from other jurisdictions, and certainly my own experience here in Ontario, is that it doesn't appear that people who are from vulnerable groups, traditionally vulnerable groups, are in any way disadvantaged by this law. That in fact, if anything, it's far and away the people from the sort of privileged demographics, if you will, that are definitely much more represented among those who receive medical aid in dying. The concern, obviously, you must have is nobody wants anyone to receive a medical assisted death that didn't want it, and when they didn't have any options put in front of them. That's what needs to be done, and that's one of the things that the law was trying to put in place, was to make sure that this is a choice. It's not about death, it's about choice.
Well, Father de Souza, we have criteria upon which to make that judgment right now. I think in the province of Ontario, as of the end of March, 367 people have availed themselves of this option under the new law. We're up well over 700 in the whole country. Is that enough for you to determine whether or not this thing is, quote unquote, working the way it was intended?
Well, there's the broader issue of where the law stands on vulnerable life, but in terms of how is it working in terms of the categories, probably not, because it's only been a few months. So in other jurisdictions where it has been introduced over a period of years, you'll see more data and so forth. So
I guess my point is, if we'd heard by now, presumably we would have heard by now if out of the nearly 800 cases, somebody had done this improperly?
It's not so much, I think, that someone comes in and does not want medical assistance in dying, does not want youth to be euthanized, and it's done behind his back. That's not what's going to happen. And the concern is more that it changes the whole ethos of care for the elderly and the vulnerable, because all of a sudden, where you had a situation where, although not everything necessary to prolong life is required, it was prohibited to do anything to hasten that or to affect it, as was the case in euthanasia. That ethos changes. It changes in palliative care, it changes in hospitals, and that will take time because it's a relatively new thing.
We are a day removed from the 35th anniversary of the Charter of Rights and Freedoms, and I wonder whether you expect in the days, months, and years going forward that we're going to see some challenge via the Charter to this new law.
We've already seen a number of challenges to this to this new law, and they are working their way through the courts as we speak. So it took a grand total of 11 days after Bill C-14 was passed that already somebody was challenging the provision that specified it had to be when somebody had a natural death that was reasonably foreseeable. The argument there being that patients who had, for example, advanced illness, and their illness would include something like spinal stenosis, which is certainly great, incurable, causes great suffering, results in declining capability. But actually, many people would not consider it to be a terminal disease, or that you may not have a reasonably foreseeable death from it. One of the two cases that was part of the Carter case was a case of spinal stenosis. So it seems a bit odd that the law meant to reflect the Carter decision actually wouldn't even apply to one of the two people for whom the case was decided. So that Charter challenge is already going through to try to take that provision out. And I've mentioned already the three sort of more controversial situations that are working their way through. We haven't seen the end of all the changes to this law. I think everybody recognizes also that the age limit defining an adult as somebody over age 18, that actually doesn't exist for most medical decisions in almost every province in this country. There isn't actually an age limit for making medical decisions, even decisions as important as life and death, that you have what are called mature minors. The simple argument being that why would suffering and why would any of the considerations around reducing suffering and recognizing the autonomy of an individual, none of those arguments apply any less to a 17-year-old than they would to a 19-year-old.
Do you want to see any kind of clarification on age?
Already we see how that what can be intended to be a guideline now becomes questioned and then gets relaxed. As far as the Charter challenges go, the original Carter decision lodged the right to assisted suicide under the right to life in the Charter. So almost anything possible can come out of the Supreme Court on this issue because they reversed themselves from before. And they understand that they're very nervous about declaring that the right to life, which is in the Charter, be eroded. So they're trying to massage this in there. And they're going to get, I think, not just the cases that are already before the courts, but there's going to be a series of these until eventually what's asked for and perhaps granted is a universal right, autonomous right at any time.
Well, let's find out how universal that is, because Father de Souza, I'll put this on the table here and then I'll get you to comment on it, because this is from the Canadian Catholic Bioethics Institute at St. Mike's College, U of T. Let's just read this. Catholic institutions and many physicians and nurse practitioners are opposed to assisted death procedures and will not perform them, and they do not offer any such procedure as part of a spectrum of care. They should also state clearly that they do not allow these procedures on their premises, nor may they refer patients directly to another physician, institution, or to any third-party agency or care coordination service that provides or arranges assisted death. Patients themselves must initiate any steps towards contacting such a service if they wish to obtain assisted death. Catholic institutions and conscientiously objecting physicians will not and cannot do that for them, since they cannot refer directly for procedures they deem to be morally wrong. A lot of issues here to follow up on. Let's try this, Father de Souza. Even Catholic hospitals are publicly funded institutions, and therefore presumably have some kind of public mission and or mandate they have to fulfill. Is there an inconsistency here?
Well, they think their public mission is health care, and they don't think that health care includes terminating the lives of patients, killing patients, which was a position that was held right across the country until about a year and a half ago. So it's not an obscure position. When you're talking about doctors or pharmacists or nurses, they make decisions all the time in professional capacities. You come in and you ask for a certain drug to help you lose weight or to do this, and they say, that's not good for you, I'm not going to prescribe it for you. And no one says you have a right to override the doctor's professional judgment. We have an odd situation where in Ontario, perhaps it might be that you can't override your doctor's judgment except in the most significant case of where he or she declines to euthanize you. There are ways for patients to get in touch with physicians who are willing to provide these services that don't involve physicians who object to them. So it's not a very difficult thing to do. In other provinces in the country, it's being done. In Ontario, hopefully that will be done, although there's some court cases around that. But also remember, the Charter of Rights includes a right to freedom of conscience.
That's what I was just going to follow up with Dr. Downar.
And the people who publicly pay for our hospitals include many people who don't want to do this. Both ought to be represented or included.
There is freedom of conscience in the Charter. There is freedom of religion in the Charter. Is it reasonable in this society today to expect doctors and or nurses and or nurse practitioners to do something that violates their conscience in that way?
It's a balance that needs to be struck here. This is not really so simple as saying that everybody must provide the given service. Physicians and nurse practitioners are not vending machines. At the same time, it's not correct to portray conscientious objection as being a trump card that just says I'm only obligated to do the things that I feel comfortable with. On the one hand, you have your right of conscientious objection as an individual, but in addition here, there's a separate issue, which is your professional role. We're not just members of the public who happen to be strolling the halls of a hospital providing healthcare. We actually enter into a professional relationship with people, and we take on fiduciary duties towards them. We must, to some degree, advocate for their interests, and if that happens to be, in this case, that. But it's an important point. Now, that doesn't, there must be some sort of accommodation. On the one hand, we can't force anybody to provide medical aid in dying, stuff that they find morally reprehensible. But the duty to us is to ensure that this person has effective access. So for some people, if you're capable of using the internet or advocating for yourself, simply aware that a service exists and you can do the rest and search on the internet. But there are many people for whom that wouldn't be accurate. You hear the story that you just heard now. If that individual did not have two very dedicated family members at the bedside, do we really think this person could have advocated for themselves and activated any sort of system with their eyes sewn shut, experiencing the symptoms that you heard described? Is that a scenario where you think simply the awareness of a parallel system to access would be sufficient to guarantee effective access?
Father de Souza, you want to come back on that?
Well, I mean, he had his family members there. He was editing his obituary. He was not incapable. He was very active. And in fact, the law presumes that the patient requesting this is making a clear decision. In fact, if there's doubt about the clarity or competence of the decision, it can't go ahead. So I think that if it's going to be the law, there are many ways the government can provide access to physicians who want to provide this service without asking the physicians who object to it to provide it. And in most of the country, I think that's going to be the case. Ontario, there's a bit of a gray area on that hopefully will be resolved in favor of the doctor's conscience. But also there's another issue, which is that there are patients who would like to be treated by physicians who are not going to consider this because precisely they come to the end of their life, they're vulnerable, they're weak, and they prefer to know that my doctor is not entertaining the possibility of euthanizing me.
Presumably that goes both ways, though. Presumably some Catholics would like to have this as an option, and their doctor may not consider it for them.
I think that the doctor or patient should be able to work in a relationship where the patient can say, I would like to have a doctor who doesn't consider this. The doctor might say to the patient, if you want a doctor that's going to consider euthanasia for you, I don't provide that. And here's a way to, there are ways where you can do that without morally implicating the physician. It's not a very difficult problem to solve if there's goodwill. In Alberta, they have a very robust conscience protection system. It seems to have agreement across the board. Ontario doesn't seem to be the case yet.
This is obviously a very new world in which we live in as it relates to doctor-assisted death. So I wondered, have you looked around the rest of the world and seen who else is doing this and whether they're doing it, I don't know if better is the right word, but better, more efficaciously than us?
There are many ways in which the culture become important then. And in deciding what rights are and how to access the system, everybody's gone about it a little bit differently and done with different priorities in place. So none of the laws are exactly the same as Canada's law, and none of the systems work exactly the same way. So in a country that has, for example, entirely private healthcare or a private fee-for-service healthcare system versus a country that has a universal public healthcare system, would the same considerations apply? In a country where everybody is in a tight little pocket, very small size, and very easy access to visiting physicians that are highly visible, a system that can be accessed by anyone very clearly, and where every physician or a large majority of physicians are willing to provide this, and it's well established in culture. Does their practice tell us what's going to work here? At the end of the day, you have to decide, look, there are very many ways to exercise one's rights. What we need to make sure is that we try to balance them, that your rights and your ability to access a service probably shouldn't depend on geography, and they probably shouldn't depend on whatever happens to be the morals of the physician that you're seeing. Again, it's not that there would be no inconvenience to you. Obviously, your experience when you have a physician who is an objector and one who is not not an objector is going to be different. There will be delays, and those have to be expected. Nobody should expect to just get what they want exactly when they want it. At the same time, to have individuals, facilities, where you may or may not essentially expect to have effective access to a service depending on which hospital the ambulance takes you to, or which part of the country you happen to be in, I think is different.
A couple of minutes left here, and I want to ask a question that you are uniquely positioned to answer. We are a day removed here from Easter Monday.
Right.
So a lot of people in our community have been thinking about Jesus over the last 4 days. And
I hope so.
we know he suffered. And I wonder if part of your approach on this issue is that life is filled with suffering, and so is death, and that's just the way it is.
Well, we heard that very moving testimony from the two ladies here about their own father. There are very few deaths where you approach them without suffering, without kind of pain, and that is part of life. The religious intuition probably gives a greater weight to suffering than, say, a secular intuition, would. So that does color the way people approach this. But regardless, anybody who's approaching death is vulnerable. Vulnerable from age, vulnerable from illness, vulnerable from something, otherwise you wouldn't be approaching that. And the intuition behind the law, regardless of whether it's religiously motivated or not, is that those lives are still valuable. Those lives still have value. When the law is changed, there's a restriction of that. There's a way of saying, okay, well, there are certain circumstances where not as valuable as others. And that's the kind of ethos that concerns me, that's introduced when you have basically legalized euthanasia. And my fear is because the logic of that doesn't end with any particular case, because it basically says that when you restrict that, there's always going to be someone outside or someone inside who wants to be outside that protection of the law. So it's true, a lot of people, when it comes to life and death, think about it in religious terms, but this isn't really a religious issue. I mean, a lot of people think about it when it's your own life or a family member, obviously in terms of their faith, but laws that protect the truth, laws that protect life, so forth, they coincide with the Jewish tradition, the Catholic tradition, the Muslim tradition, but they also have a secure secular philosophical foundation, and that's really where the shift is, because we say vulnerable life, or certain categories of vulnerable life now, don't have the same protection as they did before.
Gentlemen, I thank you for this debate. Appreciate you doing it in such a civilized fashion as well. It's a tough issue. Father Raymond de Souza, Editor-in-Chief at convivium.ca. James Downar, Dying with Dignity. Appreciate both of you coming into TVO tonight.
Thank you.
Thank you, Steve.
Help TVO create a better world through the power of learning. Visit TVO.org and make a tax-deductible donation today.